Before we move on to our presentation, I'd like to make an announcement about this year's NIH visit and first PI meeting of year three. The site visit will be held at UCLA in Los Angeles. The dates are set on July 25th and the 26th of this year. Um, the meeting will start at 4 p.m. Pacific time on Monday, and it will conclude at 8 p.m. Pacific time on Tuesday. And I'd like to remind everyone that participation from all investigators is required. Um, we've also sent out a preliminary agenda yesterday to all key investigators. Um, so before we start our presentation, are there any questions about the site visit? Okay, if not, then we'll move on to our presentation. Today, Dr. David Liem from UCLA will be presenting about how different healthcare systems are using electronic medical record data. Without further ado, allow me to introduce David.
Good morning, everyone. So it's been requested to me to at least every 6 months reiterate some rules about privacy information in electronic health records and clinical data. So part of this presentation will be a repetition from previous presentations. However, we've been working a lot now with 3 different hospitals of which we are gathering clinical data, and I thought it would be interesting to show the differences between those 3 different hospitals and how we get the clinical data from those different healthcare systems. So overall, this will be more an administrative presentation rather than scientific data, but it's not bad to have that from time to time. So as an outline, we'll have protection of health information, a waiver of authorization. I'll highlight the de-identification and CIT training, and as the last part, we'll talk about the different EHR data and how we get them from different hospitals. I'll start with protection of health information. These are all just terms that we have to go through. So aside from the financial information, medical data is the most sensitive and the most highly regulated information that we work with. And in an effort to hold organizations accountable for medical data privacy and to help them prepare their systems to strategically handle sensitive data, the United States government created the HIPAA, that is the term, the Health Information Portability and Accountability Act. This was established in 1996 by Bill Clinton. And we will further refer to this as HIPAA, and that's what the whole medical community actually does. We don't even mention the Accountability Act anymore. Everybody mentions HIPAA. And this act sets to the president for protecting medical data. And then recently, in 2009, they also established the Health Information Technology of Economic and Clinical Health Act, which is known as HITACHA here. And these measures offer technical standards for meeting regulations and provide enforcement mechanisms to penalize companies that put protected health information at risk. So we'll start with some dry terminology here. As I mentioned, the HIPAA, it contains provisions to protect the confidentiality and security of personally identified information that arises in the course of providing healthcare. In order to understand how HIPAA affects research, there are a few important terms that we need to define by the law. So first we'll cover the term covered entity, and that's the organization that has to comply with the HIPAA. In our case, that's the university. So the University of California is a hybrid covered entity because it provides 3 pillars that would have to be covered by HIPAA, which are the healthcare, patient healthcare, education, and also research. So all these 3 pillars would potentially use protected health information, and they are covered under HIPAA, and it's overseen by the covered entity, which is UCLA in our case. The privacy rule by HIPAA governs protected health information, and I will refer that to PHA, which is defined as information that can be linked to a particular person. The person is identifiable that arises in the course of providing healthcare service, education, or research. When PHA is communicated inside of the covered entity, so that's working with PHA within the lab or within a department, then we call that the use of information. But when the PHA has to be transferred to, let's say, EBI or something, then that we would call that a disclosure. And that also needs to be communicated with the covered entity and also approved by an institutional research committee known as IRB. So HIPAA allows both the disclosure as well as the research purposes of PHA, but such users would have to follow the HIPAA guidance and be part of an IRB before you start working with all the PHA information. So HIPAA affects only that research which uses, creates, or discloses PHA. And in general, there are two ways a research study would involve PHA. The first is the study involves review of medical records, and that's actually what we've been doing a lot, that I literally go into the patient health records. And that would be, and if that's the case, as the only source of research information. And this could be in both retrospective as well as prospective studies. So an example is when a researcher contacts a participant's physician to obtain or verify some aspects of a person's health history. So if we are collaborating with MDs, then you would have to ask the MD to get into the information, and the MD will follow also the rules and maybe consent the patient first, and in that fashion. So the study, and the second possibility is that the study creates new medical records when a healthcare service is being performed as part of the research. And this is usually the case with clinical trials. So when you set up a clinical trial, you would typically also set up a new medical record. So an example is the testing of a new way of diagnosing a health condition or a new drug or device to treat the health condition. So there are the HIPAA permits the use or the disclosure of PHA for research under the following circumstances. There are four circumstances. One here is the subject whose PHA is involved in the study has granted specific written permission. So if you have a small study, this would mean that you can actually personally ask the patient if you're allowed to look into his medical records, and he would have to give written consent for that. But this is typically for more very small studies. And in the second circumstance is that that the IRB has granted a waiver of the authorization requirement. So that means that if you write your IRB protocol, then in your protocol you have requested for a waiver, and then the IRB would review your case or your study. And if they give waiver of authorization, you as the PI could typically just go into all the patient information and just extract relevant information because you've been approved. But this is typically also best a long administrative process that has to be approved by the IRB. And then the third circumstance is if the PHA has been de-identified in accordance with the standards. So everything has to be de-identified, and I'll highlight that later. And if the information is released in the form of a limited data set with certain identifiers and with removed and with a data use agreement between the researchers and the covered entity. So that's a data use agreement that's actually also often part of an IRB. This is an important part. I know it's very boring maybe and very wordy, but this slide is actually an important part. We call that the waiver of authorization by HIPAA. This is something that you have to request when you set up your study, when you want to start your study and work with clinical data. This is a lot of paperwork often to have that waiver authorization. I'll go to the 9 items. So you have an authorization if the use or disclosure of PHA involves no more than minimal risk, and granting of the waiver will not adversely affect privacy rights and welfare of the subjects whose record will be used. The project could not be conducted without a waiver. So it means that, if you want to study ejection fractions in your echocardiography data, then you would have to go into the patient information. Otherwise, there's no way you can conduct your study. The project could not be conducted without PHA, which is basically similar as item number 3. The privacy risks are reasonable relative to the anticipated benefits of the research. So the IRB will typically weigh down the risks and the benefits to each other to look if it's possible to get a waiver. An adequate plan to protect the identifiers from improper use and disclosure is included in the research proposal. An adequate plan to destroy the identifier at the earliest opportunity or justification of retaining identifiers is included in the research proposal. And the project plan includes written assurances that PHA will not be reused or disclosed for other purposes, and whenever appropriate, the subjects will be provided with additional pertinent information after participation. So these are typical items that you need to consider if you are writing up your IRB or you're considering your clinical data study. If you want to have access as a PI into all the records of patients. So this is actually a very important slide. We've discussed this before, but there are typically 18 identifiers that you need to recognize if you're working with clinical information. And these 18 identifiers are considered important to be extracted or taken out from your research data. I think all 18, they make sense, but I highlighted a couple that may be a surprise. And of course, names or initials. This is actually important. You're not allowed to put in initials from the patient either. Like for instance, so that is also something to keep in mind. What also is interesting is all elements of dates are not allowed to be included except years. So you cannot even put in May 1st or a procedure on April 12th. You're not allowed to do that. That was actually a surprise, but it's basically part of the HIPAA. Telephone numbers make sense, fax numbers, all these things. Of course, you're not going to put a social security number there. This is also a surprise. A medical record number, from my perspective, it's just an innocent record number, but according to HIPAA, you're not allowed to include that as well. And all the other items, I think they make sense. And Vincent is putting all these presentations online anyway. If you want to take a look at these 18 items, or you can find them online, but the slides will be online anyway. So this is it. I'm gonna just usually once you're working with the medical data, they typically have safeguards that you need to consider, the physical safeguards. So you lock all your paperwork, you have restricted access, and paper records should not be kept in public areas. It all makes sense actually. You have technical safeguards, your computer need to be encrypted, screen waivers where access is locked after a period of time. So that's the technical safeguard. And the administrative safeguard, use of signed confidential agreements and publication of policies regarding the confidentiality and security of research data. So you need to have an informed consent. So those are 3 pillars that you always see back in all your proposals. Before anyone can participate in a clinical study or be part of an IRB, the IRB in any institution requests that you do your general trainings online, which is the CITI HIPAA online training. We put in the website here. And the website looks like this. So the whole nation basically have to have CITI online training before they can be part of an IRB and actually work with patient information. So we've been working with 3 different hospitals to work with patient information. The first one is, of course, UCLA Medical Center, and we put in a diagram here how that would work. But what I found interesting is, of course, like here, this is what we discussed before. You would design your study and before or during the process of designing and writing up your study and requesting an IRB approval, you make sure you have your CITI training, and then you start working with the IRB from UCLA in this case, and then they will grant you permission to review the medical health records in UCLA. And then what is typical, what we've been doing is that we request for a total waiver of HIPAA research and authorization IRB protocol. So all our IRB protocols have a waiver, and it means that every person that was granted on the IRB and that have completed the mandatory CITI training or the IRB approval, they can actually, theoretically, they can go into the patient health information and extract the data. So that is a very, in my opinion, relatively flexible, that every person that has been approved on an IRB in UCLA here could potentially reach patient information and start working with it. Then you would have to follow the 3 pillars that we discussed before: the physical safeguards, technical safeguards, administrative safeguards. And then you work with de-identified medical information. So you have to do that yourself, make sure that it is done. In our lab, I'm the one who usually de-identify all the information and then pass on the relevant information to our team. And we have semi-annual or annual IRB inspections. Sometimes one time they just came into our lab and that they wanted to look into our records, basically, to see if everything is well done. So this is UCLA, but we have also been working, started to work with the VA Medical Center, and that is a complete different system. So in the VA Medical Center, you also have to start with designing your medical study and communicate with the IRB. The first thing you do is, it's actually universal. Everybody has to do their CITI training, and everybody needs to work together with the IRB from the VA Medical Center in this case. But the VA have their own system, and they want specific training from themselves that only at the VA Medical Center has to be done. And it's also regarding HIPAA and also private information and annual government ethics training. But this is something that I've never seen in other hospitals. So it's a very rigorous training, and it takes a whole day sitting there basically alone, and then another month of other trainings that they want you to do. But basically, this is different than UCLA. And then and another part is that all actions regarding the VA data are physically handled within the VA Medical Center. So that was me, if I want to get patient information from UCLA, it doesn't matter where I am. If I'm in New York, I can just log in and get patient information from UCLA or from home. But with the VA, I basically have to physically go to the VA Medical Center and work from there. They don't allow me to log in from outside the VA. So that's a very different system. So if you want to work with clinical information, you have to be physically there, which also requires a lot of rules and regulations before you get a position there. And also the VA has a VA informatics and computing infrastructure, VINCI, which is more their IT structure. They handle all patient information. So I don't, at UCLA, I get into patient information and I need to de-identify the data myself. However, in the VA, they told me that they have, everything is done by VINCI, and they have a corporate data warehouse, a CDW, and there they put in all the scrambled or more the dummy data that you require. So they put it on some sort of a database inside the VA Medical Center, and I, with for instance, Vincent, if we want to work with patient information, we will have to go there and work from the corporate data warehouse. And then from there on, we have basically the same system with a physical safeguard, a technical safeguard, and administrative safeguard. But this is just a very strict and different style than the UCLA Medical Center. And then we've also been working with the Memorial Healthcare System, and this is more an urban community hospital. So Basically, UCLA is more an academic hospital, VA is more federal hospital, and we've also been working with an urban community hospital, which is also different. The urban community hospital have many similarities to UCLA. However, one difference is that people that are on the IRB do not automatically have access to patient information. It is typically only done by one PI that passes it on. So it's not so easy there either to just get into patient information, and they have a more preference to consent every patient separately because it's a more smaller urban community hospital. So that's more a difference. So if you work with medical data from the different systems, you'll see that we've been working a lot with the academic hospital here at UCLA, and what you see here is that patients often exhibit more complex medical cases, and you have more availability of advanced cutting-edge technology and procedures for therapy that are like, for instance, UCLA is a heart transplant center that would never be in an urban community hospital, a heart transplantation program, or we put in assist devices and all these more technological procedures that's typical present in an academic hospital. And you also see more rare syndromes and diseases in an academic hospital. But overall, the more severe and complex medical cases are more present in an academic hospital. If you would go for a federal hospital like the VA Medical Center, you typically see few female patients, more male patients. You see few pediatric patients, so it's more male, older male patients that you see, and there's little trauma. And then what is also very profound is that there's almost the double the amount of psychiatric patients. So that would mean that there's different comorbidities present. If you would do research on heart failure, the patients at the VA basically also have a lot of depressions or psychiatric comorbidities or addictions that may also confound your heart failure data, for instance. And then lastly, on the urban community hospital, the patient population typically reflects the city where the hospital is located. We work a lot with Long Beach. And what happens to the city if there's an epidemic in that city or some outbreak, that will typically be reflected in that patient population. As the last slide, I would say, we have the HIPAA privacy rules to keep in mind. Keep in mind the definition of the protected health information, and make sure you always de-identify your medical patient information, and ensure that all research protocols and proposals involving human subjects are reviewed and approved by your IRB, and ensure that all your investigators in your team that will work with clinical data are trained and certified by the CITA and added to an IRB. So make sure that everybody's approved, basically. That's it, and thank you for your attention.
This is Andrew here. I have one question, and I may have asked this before last time you presented, but forgive me if I've forgotten the answer. The 18 fields that are considered protected, one of them is IP addresses.
Let me, yeah.
So obviously HIPAA is really focused around health information. So number 15 there, IP address numbers, right? So I'm thinking, all of us who maintain web resources have logs of who comes to our websites. Somehow, does that, would a perverse interpretation of, or even a reasonable interpretation of HIPAA mean that those lags would be personal health information?
Andrew, I think this is really typically referring to something that is connected to a patient per se. And if I understand you correctly, you're more referring to the research projects with internet addresses or something like that. Is that correct?
Yeah, that is correct. Yeah.
Yeah. So I think what you're doing and adding internet protocol address numbers is perfectly fine, because it's more for the research team or your project. But this is typically that if if you have an internet protocol and address number from that specific patient, patient number 15, that you're not allowed to add that, basically. That's I think that's what the HIPAA refers to.
Okay.
So
Good.
if a hospital has a system where a patient could log in to check the status of like their own prescriptions or something like that, or their own appointments,
Correct. Yeah.
then the logs of that service logs would then be HIPAA.
Yeah.
Okay.
Makes sense. Thanks.
Thanks, Andrew.
Also, before we wrap up, can we repeat the announcement about the site visit we made? Because I think some people have joined in a little bit late. So yeah, so just to remind those who might have missed it in the beginning, there's going to be a NIH site visit for the HIPAA Center, and also it's going to be the first PI meeting of year 3, and that's going to be at UCLA. On July 25th and 26th, and we'll start at 4 p.m. on the 25th, and it will conclude at 8 p.m. On the 26th. Did any of the, let's see, I guess just Henning and Andrew, did you guys both get an email with information?
Yes, I did.
Okay, great. All right. Does anyone have any questions about the meeting?
Okay. I mean, if not, if you have any questions, feel free to email us. We'll be happy to answer your questions. But that concludes today's conference. Thank you everyone for attending.